Welcome everyone to the May 21st COVID-19 clinical care rounds focused on emergency department nursing perspectives on patient care and clinical operations. My name is Richard Hunt. I'm an emergency physician who serves as senior medical advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer real-time sharing of COVID-19 emergency department and emergency nursing challenges in patient care and operations. If I'm an emergency nurse preparing to care for a lot of COVID-19 patients, the nurses I want to learn from are those nurses who have the most experience. This is a voluntary public-private collaboration, thanks to the multiple professional organizations who have collaborated. These are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. The ECHO rounds you are now participating in are focused on clinicians sharing their successes and challenges in patient care and operations with other clinicians. Thanks to Project ECHO, Dr. Bruce Struminger and his team for the peer-to-peer learning platform that we use for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Tomorrow, Friday, May 22nd, noon Eastern time, we will be convening a COVID-19 clinical rounds special session on pediatrics that will include domestic and international speakers and panelists. Next Monday, when we usually have clinical rounds devoted to EMS, we'll be canceling that one due to the Memorial Day holiday. When we send out announcements for upcoming rounds, at times you'll see speakers to be determined since we work to identify speakers and topics just in time given the rapid changes in experience with the pandemic. As the pandemic evolves, we recognize the need to have general sessions and then also do deep dives on emerging issues and are working to strike that balance. For the ECHO clinical rounds, we continue to have participants from all states and multiple countries, predominantly physicians, nurses, and EMS clinicians. Thank you to NETEC, the National Emerging Special Pathogen Training and Education Center, for their support with these rounds. These clinical rounds and NETEC's webinars are complementary to each other. Our appreciation is extended to the Emergency Nurses Association and to the American College of Emergency Physicians for their support of these emergency department rounds. In recognition of EMS Week, thanks to the many who participate in these rounds who provide or support pre-hospital care. Today also happens to be National Stop the Bleed Day. Thanks to the many who have supported Stop the Bleed's mission to save lives and build resilience and have turned bystanders into immediate responders. Regarding the rounds, we receive many questions for each of these rounds and apologize that we're not able to answer all of them, but we do select major themes from the questions and hope to cover some of those. Note that during these rounds today, we'll be doing some polling questions with results shown in real time, so we'll have all of us will have the opportunity to learn together. With that, I'm going to turn this over to Dr. Bruce Struminger from Project ECHO.
Thank you, Rick, and welcome again to today's speakers and to our panelists who continue to join in these discussions, and especially to all the participants, the attendees who are joining every week and who have come today. There are almost 300 people joining us so far today. I've got a few logistic items to cover. Just a reminder, there's a Q&A function in the bottom of the Zoom toolbar at the bottom of your screen. Please put questions and comments regarding the presentations today there. There's also a chat function in the bottom toolbar. If you can, put more technical and logistic questions about IT issues, etc. There, we're also going to be asking you a crowdsourcing question that Rick will ask you in a few moments, and we'd love to get your responses in the chat. This session is being recorded and your attendance is consent to be recorded. So thank you for that. The slide presentations are linked to the most recent email reminder that you should have received today. We'll also be putting a link to the video recording as well as the slides on our Project Echo website, and we'll share that link with you, and in the subsequent follow-on emails that you'll be receiving. There will be continuing professional development credits. They're available through the University of New Mexico. We will share a link about 15 minutes before the end of the hour. There also should be a link in the announcement that went out, the email announcement that you received today. And we really value your feedback, so we encourage you to take advantage of the CME and CPD opportunity and give us your feedback so we can continue to improve these clinical rounds. With that, I'm going to hand the microphone over to Sharon Van Arsdale at NETEC to give us an update.
Thank you, Bruce. Good morning, good afternoon, everybody. My name is Sharon Van Arsdale. I am the Program Director for Emory's Serious Communicable Diseases Unit. By background, I'm an emergency department nurse. I'm also the Director of Education for the National Emerging Special Pathogen Training and Education Center. And we are so honored, could not be happier to be partnering with Project Echo on these webinars. This really allows us to do a deep dive from the NETEC perspective into some of the subjects that come up on these webinars. So we did yesterday an incident command webinar really on preparedness, mitigation, and response. We have a part 2 series coming up, really specific and focused on resilience and recovery. And then we have a couple more clinical webinars coming up based off of topics that came up during this clinical round. So one on ventilator support and innovative kind of strategies there, as well as dialysis. So the different types of dialysis that you may see in clinical care. So thank you, Bruce, appreciate it.
Great, thank you, Sharon. And we want to highlight that the AAMC is a partner and collaborator in these rounds, and they have a wonderful clinical guidance repository that they have curated. And the URL for their website is here on the slide. So we encourage everyone to check out this rich repository of clinical guidance. And with that, Rick, I'll hand the microphone back to you for the crowdsourcing question.
Thanks, Bruce. We do every one of these rounds where we do crowdsourcing clinical Pearl. And today's crowdsourcing question is, what has been the most positive unintended consequence of this pandemic for nurses? What has been the most positive unintended consequence of this pandemic for nurses? You know, it's been really hard, but I have a sense that there might be some good outcomes in with what's occurred. So yeah, I'm really interested to see some responses to that. Before I introduce our first speaker, I'd like to make sure that we introduce our panelists. So let me see, who's here? Sandy, if you wouldn't, and each of the panelists, if you could unmute yourself so we can I can move that along. Yeah, Sandy, please.
Hi, I'm Sandy Schneider. I'm the Associate Executive Director for ACEP and also a practicing emergency doc. I just want to give a couple quick updates. Is that okay, Rick? Okay, a couple quick updates. First off, happy EMS week to all our EMS staff. ACEP is planning a series to really roll out the Battle Buddy type model. I mentioned this, I think, perhaps in the past. We're going to be scheduling some trainings for buddies, train the trainer type thing. So please look for that, and I'll put that up here. I also wanted to mention our field guide. We've passed over, we're about 120,000 page views by almost 25,000 individuals, which is crazy. And never intended to be that big, but it is. And then we have a statement coming out regarding physician mental health that hopefully some of these organizations will be signing off on, asking that hospitals and state boards, licensing boards, stop asking questions about have we ever had any psychiatric care, and translate that to have we any problems with psychiatric illness that would impair our current performance. We're just concerned that that's a problem getting people to get care. So thanks, Rick. I hope I didn't take up too much time.
No, thank you. Actually, I wasn't aware of the psychiatric challenge that you've, seems like you, ACEP's helping meet. So Ron, if you could please introduce yourself, name and title, and where you're at.
Yeah. Hi, my name is Ron Krause. I'm the clinical nurse specialist for Indiana University Health in Methodist Hospital in Indianapolis, Indiana. I also am the 2021 National ENA president. So I see Mike's here, but I'll be the president next year. So
Ron, great to meet you. Great to have you on the panel. Mike.
glad to be here.
Hey, good morning, everyone. I'm Mike Hastings. I'm the president of the Emergency Nurse Association. My day job is I manage an emergency department outside of Seattle, Washington. So I've been in this COVID mix from the very get-go as well. So just a couple of things from an ENA perspective. I'll share a link as well to the Resilience video if you haven't had a chance to take a look at that. It's a performance that was done by over 60 Broadway performers. It's an amazing video that was really dedicated to the frontline healthcare workers. And really, it's really truly aimed for all community members. If you watch it, you'll see it. I start my day and end my day every day with it, actually, because it's so great. And ENA is really committed to the mental health and well-being of our members as well as we kind of face through this. And so we've actually started with some other organizations, a peer support group as well, for our members to be able to help address that mental health and well-being of everything that we face every day. So great, thanks to Project Echo and putting on these collaborations and stuff. It's been insightful and informative, so I appreciate it.
Yeah, Mike, thank you. And that video, wow. Yeah, I see why you look at it in the morning and when you go back, if you ever do go back at night. All right, so let's see, Harry, name, title, and affiliation. Can't, like mute button, Harry. There we go. Harry, we'll get you when we come back later, okay? We'll get you later. You're coming from Alaska, you know, it's a long way. Okay, so with that, I want to go ahead and introduce our first speaker, Paula Fessler. It's an honor and privilege to have you present here today. Paula is the Chief Nurse Executive for Westchester Medical Center and Mid-Hudson Regional Hospital. The Westchester Medical Center Health Network has been located at the epicenter of the COVID-19 pandemic in New York State. Paula is also a board member and the Secretary Treasurer for the American Academy of Emergency Nurse Practitioners. Paula, please, welcome.
Thank you very much. Appreciate the opportunity to share our experience today. So good morning. My name is Paula Fessler. I've been in nursing over 25 years and have been the Chief Nurse Executive at Westchester for the last 18 months. And starting at actually our first patient came in on March the 13th. We spent most of February preparing. And this is just a brief summary of some of the lessons that we learned. I focused on ED nursing, but I have to admit, I think our experience in the ED was completely dependent on how we were able to decompress the ED and move patients into the hospital during this pandemic. So ED nursing, our successes, we did a lot of, and I heard earlier in some of the conversations earlier, there were a lot of changes. You kept pivoting and making changes. So I'll refer to some of those as we go through. Certainly with intake, we actually wound up doing our pre-screening outside before the ED. We had phone numbers posted so patients could call ahead. And this was at the very beginning, before we were all in N95s in every area of our hospital. We would have patients that were concerned about exposure to COVID or being COVID positive, so that we would bring them into the hospital differently. Lessons learned as time moved on, we actually began to mask everyone. We would mask all of our staff. We very quickly, even before New York State limited visitors, we limited visitors. Our concern was not only exposure for our patients that might be exposed to our community, since our community infection rate was so high, but we also wanted to prevent our staff from any extra risk of being exposed. We wound up putting up a triage tent where we moved through first low acuity patients and then all patients. On the adult side, we also did some rearranging in our ED. Our volumes actually significantly dropped for our patient populations. And the population that dropped the most significantly was pediatrics. So we wound up moving our pediatrics ED into a very small portion of the ED where they weren't interacting and were nowhere near our adult patients, and used the former pediatric side to help expand and hold patients while we were doing their workups as to whether or not they needed to be admitted or discharged. And we also expanded telehealth, and we used telehealth actually in our tent outside to help with our low acuity patients to be seen and discharged. Infection control was a huge part of obviously everything we just went through. PUIs, when we first started our first patient to get our results on testing, was over 5 days. 5 days of not knowing somebody's status, whether they were COVID positive or COVID negative, was a lot of PPE burn, a lot of bed movement, and was challenging. Today, we actually have a 2-hour test, which has made a huge difference in hospital throughput. We also had dawn and doff coaches. And it was definitely helpful as we had different units become COVID positive. We would have dawn and doff coaches there to help support the staff, help them feel more comfortable with what they were doing, and do real-time corrections, obviously, for anything that was needed. And it wasn't just dawn and doff coaching for nursing, it was for everyone who was interacting with the patients, residents, physicians, radiology, coming for x-rays, et cetera. Team nursing and cross-trained. So we have 73 licensed adult ICU beds, and at our max, we had an additional 71 adult ICU patients. The only way we could almost double our occupancy was using a team nursing model. Nursing leadership educators, our peri-op nurses, PACU, IR, cath lab, advanced practice, outpatient nurses, and pediatric nurses all stepped into the adult med surg and ICU world. We spent most of February doing.
Yeah, that's right. I'm not sure that your slides are advancing.
Oh, I should be on slide 2.
It's all, yeah, we're seeing your opening slide.
Let me. Oh, I'm sorry.
No, don't be
Let's
sorry.
see.
It's
There we go. How is that? Is that better?
That's great. Yeah.
Thank you. Thank you for stopping me. I appreciate that.
Well,
So,
put the slides together, you know.
Absolutely. 2 screens. So I saw the right one in front of me, but it wasn't in front of you. I apologize. So advanced practice, outpatient, pediatric RNs all stepped over into the adult world, and we spent about 6 weeks doing that cross-training to get them ready. And then throughput was probably the most important impact we had in the ED. We really worked hard to keep the ED decompressed. We were opening new beds for ICU patients upstairs. We actually probably performed better on our throughput with COVID because we wanted to be ready and have the ED available to take the next patient than we do on some of our normal days. So Dr. Hunt, when you asked what were our lessons learned, we learned we can decompress the ED very well, and those are things that we want to make sure that we maintain and continue that practice as we get into the post-COVID new normal. And we definitely significantly limited our inpatient boarding. And then ED discharge, we did a lot of follow-up wellness calls. We were discharging patients who we wouldn't have discharged before. They had certainly lower oxygen saturation than we would be admitting them. We were sending them home. So we quickly put together a follow-up program to make sure that we checked on them and ensured that they were still safe. The next slide, our challenges. I think this piece is probably the one from an emotional standpoint was the hardest piece. We had a lot of fear. Nurses were afraid that they would be sick. I had approximately 10% of our workforce out at our most challenging times. So again, that cross-train and team nursing was really critical to be able to provide the care that we needed to do and to support the frontline teams. I also had a lot of nurses that were worried that they'd be bringing illness home to their families. Our health system actually collaborated with a lot of hotels nearby. We offered free rooms to staff that didn't want to go home, which was a nice option, but that's not for everyone. So how do we reassure? We provided scrubs to all of our COVID units who were taking care of COVID positive patients. And actually by the end of March, we treated everybody like they were COVID positive, just with regard to PPE. Negative pressure rooms were another challenge. When we first started, we actually opened up a 5-bedded negative pressure unit just for COVID. And within a week, that couldn't meet our needs. We quickly outgrew that. HEPA filters were a challenge. We first initially wanted everyone in a negative pressure room, or at least with a HEPA filter, and then we quickly, our supply and demand didn't match. So then we got to the point that anything that was an aerosolized procedure needed a negative pressure or HEPA filter. We did lots of room transfers. Our nurses were absolutely amazing at being able to be flexible and move, but it certainly added a lot of steps. PPE, before COVID, even before we had our first positive patient, we were flying through PPE. And I'm not sure that it was so much that people were using it, but we could have boxes just disappear. So we actually locked down our PPE. Nurses were in charge of it. It was put in our med rooms just so that it was a little bit more controlled. And the point was we wanted to have PPE here and available and ready for our patients and staff and have it available. Floating, we floated a lot, which was not usually a well-received piece here. And yet I have to say everyone really stepped up. They understood the situation and we got through it. How many more patients? There was one Sunday that I can't even count how many patients got upgraded from the floor into ICUs. So I think that was a really real fear, like how much more can we do? And once we hit our peak and started coming back down, there was almost instant relief that people at least felt we weren't at our max and we had made it. And then the wind down, that's where we are right now. We're at about 50% of our max, maybe just a little lower than that. But the wind down back to the new normal has definitely been a little bit of a challenge. And some of it is obviously we still have COVID patients in the hospital. We still have a few coming in through the ED. But how do we keep the lessons learned, what we did really well, the collaboration, and also return to what we need to do, which is our regular business. So it's an exciting time, but still a lot of moving parts. And then the other piece I wanted to talk about is disconnected families and social isolation, because I think that was a huge impact to nursing. The first one was patients not having their support, not having visitors and families in the hospital was hard. It was really quiet, took a little getting used to. And then the really difficult part was patients dying alone. Nurses became really the true conduit between the patient and the family. We did offer end-of-life visits to come in and we to families if they wanted to come in and say goodbye, and we helped them don and doff. Not every family could take advantage of that. We implemented a very robust iPad, FaceTime, and internet connection for video calls with families. Our nurses are offering to do a video call twice a day so that we can help bridge that gap that was created by the limitation of visitors. And then not only was that hard for our patients and their families and our staff with that piece, but I think the other part is just our healthcare heroes, which is what we call our frontline staff, is the isolation that they had. You know, most of us have always coped our entire career by interacting with others and, you know, certainly getting together with friends and family outside of work. And all of that changed for the entire country. So I think that added to some of our coping and finding new ways to connect with people. Lessons learned. Leadership. The only way we got through this actually was from an incredible group of leaders here, and they were present. I believe that you can't lead from home. You need to be there, answer questions, and really it takes a team to get it done. Acknowledge fear, talk to staff. It was very real, and build trust. Listen, share stories, and then celebrate victories. So not only did we celebrate our COVID discharges with a little routine that was actually quite exciting and went over very well, but we also did a lot of small celebrations and acknowledgments of staff along the way. Certainly Nurses Week was very different last week than we've ever had in my career. And yet we were able to do it very successfully, just in new ways. And then planning. My advice for anyone that hasn't been there, or maybe they're just getting to get into this a little bit, or a second wave, get to where you want to be. We spent a lot of time writing a policy, and 2 days later we wrote another policy, or we moved patients to one unit, and 2 days later we were moving again. So really have that long-term vision of, if it gets bad, where are you going to be, and work to get there more quickly. I think that would limit the stress of multiple changes. And then the one piece that will never change is the cross-training and maintaining competencies for our nurses across all units. When the ED volume was as low as it was, we actually had ED nurses come up and work in our ICUs to partner upstairs, which usually we partner the other direction because it's the ED that's so busy. So it was really, truly fantastic, and definitely a challenge from a very unique experience that I've never had before, but one in which I'm really grateful for the team that I have, and that we're on the other side at this point. I've included my contact information here. If anyone has any questions, would be happy to connect with anyone offline, and certainly thank you for the opportunity to present today.
Oh, thank you so much. I do have, there's one question, well, it's a few questions in one space. Question to Ms. Fessler: how did you keep social distancing in the waiting areas, especially the COVID-19 suspected input areas? And were all ED visits by appointment, and did people have to wait outside in other areas? You know, it's like a multi-part question, but I think you get the theme of it.
Absolutely. So we actually closed and locked our lounges. We removed all the furniture from many of our public areas. And then we actually wound up adding back a tables with one chair at each table to be able to have staff to eat in the cafeteria. But that was, you know, some of our lessons learned. We still don't have visitors in our building. We escort visitors when they come in for an end-of-life visit or for an extenuating circumstance visit that's been approved by leadership. They get escorted in and escorted out. And you had one more question. What was the last question? I'm sorry, Dr. Hunt, I don't remember.
Did people have to wait outside in other areas?
They did not have to wait outside. We brought patients in, but the ED, we only had the patient come in, and we immediately would get family contact information, and the family either would wait in their car or they would leave. And that was really hard. The one caveat is our children's hospital. Our children's hospital, we did allow one designated support person to be present 24 hours. And same with our birth center, they could have a birth partner with them as well.
Thanks, Paula. There are a lot of other really great questions, and I want to make sure we're able to move on to Dan Nadworny, who is joined us today, and he is currently the Director of Emergency and Patient Care Services at Beth Israel Deaconess Hospital in Milton, Massachusetts. Dr. Nadworny has worked in emergency departments in the Metro Boston area since 1999 and has a specific interest in emergency preparedness, and has worked with the ENA, where he served as chair for the National Emergency Preparedness Committee. Dan, please, realizing it's going to take you a minute to get your slides open.
Thank you.
While you're doing that, getting your slides open, I want to let you know that the responses to the crowdsourced question about the unintended consequence, there are some great responses to that. The one about the BP discount, that one I wouldn't have thought of. Great one. All right, so Dan, please. Thanks.
Great. Yeah, well, thank you for having Dr. Hunt. Great to see so many people from all over. And thank you to Paula for her comments. I have to agree with everything she said and how interesting it's been to be part of the journey as a nurse leader in the organization. So again, you know, I wanted to take something similar to what she had said, is how we do things. And even before all of this started, you know, where were we? Because I think that's an important part, is what were emergency departments looking like before COVID started? Our role has always been to be ongoing education, community support, being there for our neighbors. Emergency medicine, our doors never shut and we never turn anybody away. And as COVID started to declare itself as being something as a risk to our environment, we started talking about it. And this is nothing new. I think, you know, Mike and I have been working together for a couple of years now on disaster planning at the ENA level. Preparedness and has been always there for us, whether it was H1N1, SARS, Ebola, or the small measles outbreaks that happen in communities from time to time. This has been part of our culture. What's been different has been to take some of the practices we've put in the emergency room and bring it up to the rest of the organization and really show how disaster planning, yes, it often is related to a small moment in time where we have things like an explosion or a train accident or those things, but it comes through. And so surge planning has been part of our conversation. And like Paula said, is we realize we actually can decompress our emergency department. We can do things. It's not always easy, but prior to this, ED overcrowding was a major focus for us. And another part what we really were concerned about is our behavioral health patients. The lack of behavioral health beds in the country is a major problem. And you throw a pandemic at this in an environment of people who don't always follow rule sets about hand washing and social distancing. How would that come out in the wash with these things, and where would those patients end up, and are they going to be more of a vulnerable population for us to care about? So those are some of the things that started all before COVID. So what was our reality for us? The hospital I work in here is we're a community affiliate hospital from a larger network. So the Beth Israel Lahey Network is 12 hospitals in Eastern Massachusetts. We're just under 100-bed hospital with 3 med-surg units and a 20-bed emergency department. So a different picture for us. What we saw was the balance of the increase and decrease. The increases that we saw was this high acuity patient mix that came through our doors. We typically would run about a 20% admission rate. And during that peak time from mid-March to April, we were upwards of 40% admission rate if you combine our transfers plus our admissions that came into the organization. And those high acuity patients, the first couple were scary. I think most emergency nurses that I've spoken with, the first couple that they saw walk in the door, you put the sat on the person's finger and you saw a sat of 50%, everyone switched the pulse ox out because no one trusted it. It's like, wait, no one can have a pulse ox of 50% walking in the door. I'm not at elevation. I'm not on top of a giant mountain. This can't be right. And somewhere between the second and fourth O2 sat probe, people started to realize actually that might be right. And then we started to see the picture of that's what they look like. And we developed this understanding of the presentation of these patients, especially the ones who really had significant illness that came in and they'd have these low O2 sats, be mentating in within 2 to 3 hours. We're either proning them in the emergency department, which was completely different, or we've already put a tube in their throat and they're moving on someplace else. So that frequency of presentation, but then with codes and intubations, taking the page from back when we did Ebola of how we need to simulate high risk, low volume events is essential. And we actually early on did some work where we actually each morning did a practice intubation round with our ED staff, physicians, respiratory therapists every morning before shift started to have people put the PPE on, go through the PAPRs, not just putting them on, but how do you take them off? And several times we did that just before codes happened, which I think was a great thing to do. We burned through PPE. Every time our logistics person would get on our HICS calls, be like, okay, so the ED needs to stop using gowns. And I'm like, well, the patients need to stop coming in because that's pretty much the one-to-one barrier here. And we were trying to calculate down PPE burn rates of, is 6 gowns per patient a realistic number? Should we be sharing gowns? And I think that's an increase that we went through. Telepresence, we tried using telepresence to reduce caregiver time at the bedside, using providers to use a secure web link to be able to do med reconciliation, to be able to do your social screening things that didn't necessarily need to have bedside presence for. Some patients are better with it than others, but it was an opportunity. Education with new techniques and new structures, like I mentioned, proning was some of those things that I don't think we had never even done here in the ICU, never mind in the ED, and to teach through that in real time was really something that was interesting. But at the same token, it was the disruption of normal care. So we're not going to focus on the education of our daily activities. Those things need to take a back seat for the pressing issue of the day. So even though we needed to talk about nutrition for these patients early on, it was more about the immediate life threats. And a lot of end-of-life discussions in the ED. That was something that was really surprising for me, was how many times we had conversations with families about converting to CMO status. And I think the lack of non-invasive ventilation played a role in that, because we early on understood that if we put a person and intubate them, it's going to be a much harder discussion for a family member to remove a ventilatory status than it is when we used to put people on BiPAP and say, okay, well, we're not going to progress to the next step. Now we've lost that step. So now it was either non-rebreather or intubation. And that did lead to several conversations in the ED for end of life discussions, which is not our normal, I think, our normal pattern. And reaching back to others who had expertise in it or support through pastoral care in the organization was essential. The flip side of that is what decreased. Our volume dropped. I'm not sure where all the trauma, strokes, and STEMIs went, but they didn't come here. Gravity seemed to all of a sudden stop occurring. The nursing home patients were not falling out of bed. I don't know. We're still trying to figure this out. They're starting to identify that gravity still works this past week. But it allowed the ED, and I think we prepared and we had this feeling that we were going to be overwhelmed in the emergency department. And for us, it just didn't happen. We had the ability to move people upstairs. And again, like Paul said, is our ED staff actually were able to augment themselves and flip and help inpatient, which was great to see. Supplies, huge issues. I think we can all speak to this. There's the haves and have-nots. The have-nots included N95s for a period of time, ventilators. We got close to not having enough vents for patients, vent tubing, nebulizer treatments, endotracheal tubes, glide scope covers, all those things. And you realize how reliant on the just-in-time programs that we really are. So hopefully that'll come through. And then how we get people out of the organization. Resources are a huge thing. I think Mike mentioned this before, working with ENA, especially of looking at what the best practices that are out there, whether you're looking at PPE or even how do we care for ourselves and care for each others. So what were the concerns for us? Like I said, triage and screening was probably one of the bigger ones early on for ER. Where were those patients coming from? What was COVID? What wasn't COVID? Went from being in Wuhan province, Wuhan city, to China, to Boston pretty quickly. So our triage algorithms were changing pretty much every couple hours in some cases. And we got to the point where just about everybody coming into the ED was a PUI for us. The PPE and how we were able to actually work on that. PPE discussions, I think for many of us, it moved from being about science to being about culture. So the science was telling us that more than likely this was a droplet environment, but there was a culture where people really felt that the only way they could safely work was with full N95, full face gear. And we had to make the accommodations on the leadership side of, okay, how do we balance those two between supply, science, and culture for PPE? And I think even to this day, as we try to come back to the real world of whatever this new altered care state is, we still have to balance that, because I don't think anybody will see it as anything other than pulling back or reducing PPE if we go to pure surgical masks. Staff well-being, the amount of exposure to death and end of life that I think our staff saw was a concern for many of us, and the fear. And I think as a nurse leader, one of the things that I found was that staff were behaving in certain ways, often not because of they were educated, but their fear was driving their reactions. And that a person who didn't want to float to the floor, they weren't acting out because they didn't want to work on the floor. That was their way of kind of pushing forward whatever fear they'd had over the past 2 weeks. We had people who snapped, who never snap. And I think it was something for me to understand and look at a person and say, when those things happen, it's not to react like I would typically, but the first thing would be able to pull that person aside and say, I need you to take 5 minutes. Are you okay? Are you safe? What are the things that you need to do to make sure you're actually taking care of yourself? And then we can come back to the behavior piece of it, because a lot of it was more about fear. And then those discussions about scarce resource allocations. Where are we going to have enough beds? Where are we going to have enough ventilators? Thankfully, we were able to manage that, but I do think it was close on a couple of days there. So where were our successes? These are the numbers in Massachusetts as of yesterday. As you can see, Massachusetts never really had a huge spike. We went up pretty quickly, but then we didn't have an overwhelming number of cases that happened. We're still having cases happen every day. As we open up the state back to normal or new normal levels, that was one part. So I do think the stay-at-home orders in this area were essential for us to be able to do that, and also to have buy-in from the communities about how the EDs were acting. How we work as an inter-unit. in between the units in the hospital, being able to have the ED staff be part of our proning team for med-surg. Our ICU typically would respond to our rapid responses on the med-surg units. During the peak of this, the ED actually took over that responsibility because the ICU was just too busy. The load sharing across the organization, being part of the network, we actually transferred 266 patients out of our hospital between March 1st and April 15th out to other organizations and other hospitals in each of Massachusetts. So that load sharing allowed us to never really push beyond surge space, although we did go to 160% ICU capacity while we were in the middle of this. And then public support and daily innovations. So I think our staff did a great job of trying out new things and saying, hey, I think this will work, let's try it. And they were right many times. So many of those daily innovations we're going to try and keep, whether it be code cart jump bags, so we don't have to bring the whole code cart into a room, use of baby monitors to keep track of patients, all those different things. And the last really was the success of how much public support we had. You know, Fenway has been closed with the start of the Red Sox season, but this was what was posted. They actually put this right in the lawn in Fenway last week for Nurses Week. So you take that, and with EMS Week this week, you know, it's been an interesting thing of seeing the public support across the organization in the region. So I think that's been my learning point. This has been, you know, we have the ability to pivot. It takes this community to really have success, and that's how we all succeed.
Thanks, Dan, so much for your presentation. One really quick question, then I want to do some polling and then get our panelists to comment. The proning, as we began these rounds, I think within the, like, maybe the beginning of April, we started hearing about proning that was happening in the emergency department, then some EMS agencies, so forth. You know, in emergency departments, emergency medicine and in medicine, you know, new drugs are introduced all the time, but this is like a totally new, you know, proning in the emergency department. Where'd that come from? So for your institution, how did it get into your emergency department? How did proning, I mean, did somebody from the unit say, hey, you ought to try this because, you know, it's going to take us a while to get the, or how did that actually happen?
So for us, it was a natural progression. Being part of a larger system, a lot of the attendings share between sites. So the docs that are here on Monday may be at the academic trauma center on Tuesday. So the practices that were being talked about were almost real-time conversations about what is the best practice. And as people started talking about it and seeing demonstration of success, it just moved forward. And especially for self-proning, it didn't take anything. So for patients who are awake, alert, you just help them roll over and you watch the SATs improve. You do that 1 or 2 times and you see how things happen. And, you know, part of it was the discussion with staff trying to understand, well, why is this helpful? And we had a couple of our intensivists who were able to either give us direct information about it, but showing how that the location of the chest and how that it reduces the resistance was just great. And we also were able to do on the med-surg units, modified proning for patients who couldn't go to full prone position, putting them on the side of the lung that the chest x-ray showed consolidation for lung recruitment. Just as it demonstrated, it just spread like wildfire. And we saw a success.
Yeah, and the part of why I'm asking, I can talk about, you know, high flow and these other things too, but in our clinical experience, in our respective careers, it's rare when something, an intervention suddenly, like in a week's time, gets introduced, and how that happens is something I think for the future it's really important to understand. I want to go to polling next, and for all of you who are, like all 363 of you who are multitasking away, I need you to focus, just focus, like get back on the screen and get ready with the mouse because we're going to do the polling thing. So the way this is going to go is we're going to put up these, each individual poll question. And some of these, it's going to take you a little while to like think through with a response. Many of them are quick yes, no's. Some of them are exclusively for our nursing participants, and those will be indicated as such. Some of them are select one answer, some of them are multiple choice. So or multiple responses. So Echo, if you could start with the first one, please. Okay, this one's going to take a little time for you to think because it's like your best answer. For nurses, which one education topic do you feel like you are missing that would make you more successful in the COVID-19 response? Select one. Doffing of PPE, strategies for mental health support, strategies for physical health support, COVID-19 pathophysiology, treatment, clinical operations, testing, and HICS. I should have had an other there. And as you see at the bottom, hosts and panelists cannot vote. Host, yeah. So it'll be like 10 more seconds for this one, 15 more seconds. It's like you only get one answer here. Okay, stop. How about that? Sharon, that should help you. All right, next. This is about physical health for nurses only, okay? Which of the following has been the most effective in supporting my physical health? Select one. Running, yoga, strength training, cardiovascular training, keeping to a regular sleep schedule, other, and none. Yeah, just one. And 5 more seconds. Okay, stop. Sleep. Us shift workers, you know? Next. For nurses, this is mental health related. Which of the following has been the most effective in supporting my mental health? Select one. Coworkers, family, friends, meditation, the organization I work for, my professional society organization, my doctor or other healthcare professional, telehealth, telemedicine, and other. So you just get one choice for nurses only. It'll be like 10 seconds. I'm actually really anxious to see a response to this. Okay, stop. Thank goodness for family, huh? All right, next. For nurses only, support of my mental health is more than adequate, adequate, insufficient, or non-existent. Five more seconds. Okay. Kind of a bell curve going on there. All right, thank you. Next. For nurses, in the next 6 months, I plan on working at the same place I am today. I plan on leaving emergency nursing. I plan on moving to a different emergency care workplace, or I plan on leaving nursing. It's like 10 seconds. Okay. Wow. All you nursing leaders, you ought to feel good about that one. That's That says a lot right there. All right, next. For nurses. Since COVID-19, my number of work hours has increased, decreased, or stayed the same. That's pretty straightforward. Okay, you stop. That's pretty variable. All right, next. For nurses, since COVID-19, my pay has increased, decreased, or stayed the same. Okay. I'm glad it wasn't a disaster. Good. Okay. Next. And when we put this next one up, as we do that, you can read it. But for the panelists, what I'll do immediately after these, and we're getting to the close of them, I'll just go around the table, asking for any quick comments, reactions to either the panel or anything that our speakers have presented, and then go to our speakers for the last word. I know a nurse who has been unable to work one or more shifts due to mental health impact of the pandemic. Yes or no? Okay. All right, next. What is the most important challenge nursing will have on June 1st, 2021? So a year from now. Nurses leaving, you just get one response. Nurses leaving the profession, absences from work, nurses' mental health, nurses' physical health, recruitment of new nurses to the profession, nursing school financial challenges, maintaining nursing education requirements, or other. So you get one. I think there's one more after this, I think. Okay. Interesting. Next. Our organization is preparing for a second wave of COVID-19 patients. Yes or no? That's pretty straightforward. And then we'll, after this, we'll go around to our panelists and then to our speakers for a quick comment, reaction to anything that has been said during the round so far. Okay, stop. 91%. Actually, that's gratifying. All right, thank you. Thanks, Echo. You do a great job in getting those up. Really. Thank Bruce, Amanda, Amy, just awesome. Thanks for doing it. Okay, so let's see. Ron, why don't we start down with you? Any comments on or questions based on what you've heard today?
No, I was just saying, I would agree. I think one of the things we're gonna have to watch is the mental health of the emergency department and anybody on the front lines. Because I think, unfortunately, this hero phenomenon thing is probably going to go by the wayside here quicker than we really want it to go. And I would agree with Paula, the wind down is going to be very difficult. Here at my facility already, we're seeing, we thought we had the throughput issues all figured out during, oh no, Monday we were camping patients just like we did before COVID. So it's one of those things go right back into that. So it's stuff to watch out for.
All right, thanks. Sharon?
Yeah, could not agree more with my friend Ron. I think this, the crowdsourcing question really, that was really powerful to see. The unintended consequence of this pandemic for nurses. I don't think I've ever been more proud to be a nurse, especially an emergency department nurse. The community, we've all come together, it's just been really, really amazing. What is really encouraging is the question, and this question was asked, I think, last week, and Mike and I both made comments on it. The percentage of staff or individuals that think that they'll be in this position in 1 year.
Yeah.
I thought that more people would be leaving the profession. So it's really encouraging to see that 95% of folks out there think that they will still be in the same emergency department in 1 year.
Yeah.
It's really amazing.
Yep. Harry, quick comment. You're still muted.
Good morning.
There you go. Go for it. Harry, I'm sorry. We're going to catch you the next time. Yeah, the connection just didn't working. Worked great last week. What the heck? Who knows? All right. Flow of the life forces. Mike.
Yeah, so I mean, I think the panelists, the speakers did a great job presenting their challenges. Just kind of like with Ron at my hospital where we're at Monday, all of a sudden I was boarding 12 patients in the ED. So we celebrate the fact that we had throughput for a little bit, and then now we're back to kind of status quo as we start reopening things up. So, but I mean, again, ENA, we're here to help support the members as well. It's been a great partnership through this COVID to get through, because we can't do this as alone. As like Paula noted, that the ED nurses were going upstairs on the floor and cross-training stuff. We're all in this together, and so we will get through this together no matter what we face. So,
Thanks, Mike. Sandy?
So I just want to say, first, thank you to Rick, because this was a really good session, and all of them have been. The second are to the nurses, because you guys have always been our partners. We've always been a team. Neither one of us can do this by ourselves. And I think the appreciation for each other has always been there, and perhaps if nothing else has grown. I do think that will be essential for us to continue to work together because the letdown from this, like a letdown from any other disaster, is going to be, I think, larger and more serious. And I just hope we will continue to work together. And again, thank you. It was a great session, and I learned a lot. And I really, really, really appreciate the work that all of you are doing.
And Mike and Sandy, thank you for your extraordinary helping me recruit stellar speakers. Dan, final comment before Paula's final comment.
Yeah, again, I think, disasters are going to happen and disasters are going to occur again. I think one of the biggest tragedies would be if we educated and learned all the things that we've learned in the past 9 to 10 weeks and then just went back to normal without recognizing the amount of work and not maintain those skills. So I hope we can all learn and maintain the skills that have been there, and also maintain the respect for each other that's been built over the last 9 weeks. Walk in your shoes, walk in my shoes. They're all long walks some days.
Thanks, Dan. Paula.
I completely agree with what everyone else has shared. I think the continued surveillance for mental health. I failed to share that we do have a mental health hotline that staff can reach out to that's internal. But I think we are going to have a long time with dealing with just the outcomes and everything that's transpired. Getting back to our normal, someone had asked the question, what does that mean? What are our issues? We still have COVID. We still have COVID floors. We just started elective procedures on Tuesday. So how do we do all that balancing? And that's going to continue to force us in a great way, I think, to have those conversations that we started having with COVID. And those would be the pieces that we want to move forward. So thank you.
Thanks, Paula. Yeah, thank you. Bruce, anything before we close?
Just thank you to Paula and Dan, and I see Harry wants to make a comment, so we're going to give him the floor. He's figured out how to unmute himself. But thanks to everyone and all the attendees, and please fill out the CME, CPD, give us your feedback, and Harry, give us your comment.
I'm having some technical issues. I'm hoping you can hear me okay, Rick. Oh, great. Sorry about that. I'm using a little bit different equipment this morning than I have been. The two comments I wanted to make is I think this has been great because it's brought into sharp focus what several people have mentioned, how important the teamwork is. And that's everybody from the guy cleaning the rooms all the way up to the CEO of the facility. but within our team, in the emergency department especially, it's really brought into focus how important all the members of the team are, not just one individual. We can't do many of these tasks that we're having to do during this pandemic by ourselves. So it has brought that into sharp focus. And the other part I found very disturbing was the polling response of how few people responded that their institutions were giving them great support. And perhaps this is a call to action for all of us, that is a real detriment to our healthcare workers and is a real area that we need to improve at an institutional level. Our institutions really should be recognizing the stress and the risk to us, both as healthcare workers and to our own mental health and our family's mental health, by not having that institutional support. So thank you.
Yeah, I think if there was ever an opportunity to change things for the better, this might be maybe the best we've had in our career. So we ought to go for it, seriously. So with that, I want to thank the participants. Thanks for doing the polling thing, paying attention, being right on it. Thank you very much to our troops at ECHO, stellar as always, and our panelists. Thank you for the comments. You're joining us, and to our speakers, just gratifying to hear your experiences, and keep on doing what you're doing. Thanks all, and to that individual from Armenia, hi, and keep joining. Bye, everyone.